Hi, I'm Bob Kaplan from the Stanford Clinical Excellence Research Center, and thanks for having me today. I'm going to talk about rehabilitation payment models, innovation, and research and policy. So let me begin just by briefly saying what the Clinical Excellence Research Center is. We're the first U.S. university-based center that's exclusively focused on cost of great patient care. And we do a wide variety of studies around the cost and quality of hospitals in the United States and services. So this is just an example of one problem that we're working on that looks at US hospitals, which you see on dots in this graph. And then we've made the dots larger or smaller in relation to how much money they charge private insurers in relation to what the same hospitals accept from Medicare. And so the color of the dots represents quality. So the purple actually is the highest quality. And what you can see here is that actually across the country, there's one facility that charges for inpatient care way, way more than anybody else. And that's the Dana-Farber Cancer Center. And here are all the hospitals in California. In this case, these are charges for outpatient services. And you can see that they vary in size and vary in color. So the orange represents relatively low quality. And so we have a couple facilities, for example, this one that has relatively low quality, but actually pretty high costs. Or there are areas like the San Diego area, where in fact, most of these hospitals are in the red or purple zone, which means that they're high quality hospitals and their costs are relatively reasonable. So you can see, for example, that the costs ratios in the Southern California area are much lower than they are in the Northern California area. So I want to just begin my discussion today with the discussion of the apple pickers and federal judges problem. And this relates to this issue that we're going to be talking about throughout this meeting, which has to do with reimbursement models. And so I was working at the Agency for Healthcare Research and Quality a few years back, and we talked about this problem in some detail. We realized that some payment models are more like the payment models that you would use for apple pickers. So apple pickers are paid by the apple. So the more apples that they pick, the more they're paid. And in fact, you can even pay for good apples. So if it's a bruised apple, you might not pay for them. And it's a model that produces a lot of apples picked. And then there's an alternative model, which is payment on a fixed salary. So that you could pay, for example, federal judges, and they might be paid on the basis of hours that they put in, or they might be paid on something more like a fee-for-service model. For example, they might be paid for conviction. But people realize that that's really a bad idea to pay judges based on the number of people they convict. It provides an adverse incentive to administer justice. So when we look at these different models of reimbursement, this is a skeptic's view, but you might have a model that's a fee-for-service model. This is the apple pickers model. And the incentive is to do as much as you can for as many people as you can. But the consequence is that you get an over-provision of services. So there are a lot of short-term visits. There's not a lot of incentive for quality. And then we have the federal judges model. This is a salary-based model where a skeptic would say that you do as little as you can for as few people as you can. And the result is very low productivity and no incentive for better access to care. And then finally, we have something like a capitation model, more like the Kaiser Permanente model, where the skeptic would say, you do as little as you can for as many as you can. And here the incentive is to seek healthier patients, that is to try to slant your marketing so that healthier people enroll. And it can result in low quality care. So I'd like to probe this a little bit more by trying to link these models of reimbursement to what we're trying to achieve in medicine and healthcare. And this brings me back to a paper that was published probably 70 years ago by these two gentlemen, Archie Cochran and Sir Bradford Hill. And what these two sort of icons of evidence-based medicine argued is that the purpose of healthcare is to do three things. You have to see if you can answer the question, does what you're doing work, or can it work? Does it work? And is it worth it? So let's start with the question of, can it work? This is just a binary question. So what kinds of research lead to an evaluation of the can it work question? Well, the argument is that the can it work question represents just about everything that we do in healthcare, that it's basic lab science, phase one, phase two, and phase three randomized clinical trials. And this sort of was what we were doing in what we call the first era of healthcare. And these eras of healthcare come from my friend and colleague at UCLA, Neil Halfon. So Neil argued that we had a first era of healthcare, which maybe was the era of yesterday, that was based on the germ theory of disease, that thought about very short time frames, and the service that was offered was medical care. And the financing was basically a fee-for-service model. It was an insurance-based model, but basically it was the apple pickers model. And the goal was to reduce deaths. And it was built upon the science at the time. So science and medicine was based almost exclusively on the germ theory of disease. So what you saw under the microscope. And in fact, we like to argue that this dominates how we spend money at the NIH currently. So if you look at this graph, the blue bars represent what the NIH is spending on basic science, and the red bars represent what they're spending on applied science. And you can see that NIH says they spend roughly half basic science and half on applied science. But in fact, most of what you see in applied science is really fairly basic science. That is, it's almost always getting at this basic question of, can it work? But not necessarily, does it work? So let's look at the does it work problem. We know from a lot of work that's been coming out recently is that there's a problem with replication of science. There's problems with efficacy versus effectiveness. And I'll get into that in a little bit more detail. But we know that studies are biased when they have exclusion criteria, and substantial numbers of people that might be eligible for a trial get excluded. So to just begin our exploration of the can it work versus does it work, I'd like to tell you a little bit about generalization of animal models to humans and how that might be a problem. When I was working at the NIH, I gave a lecture one time with a colleague, Robin Barr from the National Institutes of Aging. And one of the arguments that Robin made in his presentation was that we've cured Alzheimer's disease about 300 times in mouse models. Very impressive. But so far, we failed to cure it in any humans. And he was referring to a systematic review of 221 consecutive phase 3 placebo-controlled trials. Each one had failed to show a benefit of a new therapeutic for Alzheimer's disease, despite the fact that, in fact, these same molecules work very well in mice. And in fact, this gets at this problem with the attrition rate in clinical trials for Alzheimer's disease, which has been at least 96%. So one of the difficulties is that the traditional basic science model, although impressive and still certainly using a lot of our investment in biomedical research, actually has failed to produce the results that we hoped it would, largely for these reasons: generalizability and the poor connection between just modifying molecules versus affecting outcomes in humans. So we have to move on to another phase in healthcare, another era. And so what happened was that science moved on from this sort of basic model and the germ model of disease to another sort of era of science. And this was based on sort of revolutions in epidemiology and public health science. And those new findings forced us to rethink what we were doing with healthcare. So the second era of healthcare focuses more on chronic disease and on multiple risk factors. And it allowed healthcare to be moved from the primary site of delivery, which was hospitals in the first era, to outpatient clinics, as you see in these pictures. And the financing model began to change. So we got into prepaid benefits, in some cases on capitated care. And the model of healthcare delivery became more corporate, and the goals became different. So instead of just preventing death, healthcare began thinking about prolonging disability-free life. So I'm just going to skip this and say that we do know that medical care has made remarkable achievements. And so, for example, when I was at NIH, that the director used to go before Congress and say that our nation has gained about 1 year of longevity for every 6 years, way back to about 1900, so that a child born today can look forward to living an average of about 78 years. That's actually about 3 decades longer than they were in 1900. And in fact, part of the testimony for the NIH budget showed figures like this one showing this remarkable and dramatic decline in deaths from heart disease over the course of a relatively short period of time. So we might ask, well, how did we do this? And the argument is that we did it using a basic science model. That is, we identified basic mechanisms of disease in clinical research. And in the clinic, we diagnosed the problem. And so we found the problem, had better diagnostic technologies. And then using evidence-based interventions, we treated the problem. So the model is basically a find it and fix it model. And in fact, this is the way biomedical research is often presented to the public. So in this slide, you see these two women. This is an ad from the pharmaceutical industry. And the narrative is that there's this very smooth transition from bench to bedside. And in fact, you see ads like this one that I picked up from a Toronto newspaper when I was visiting there, where they argued that if you have cancer, you just go to the University of Toronto and have your cancer switched off. Now, the problem is that the basic mechanism model actually has not worked quite as well as people think it has. So if we just look at this basic assumption that if we learn the mechanism of disease, then that will automatically lead to a cure that will result in better patient outcomes. So part of this argument is that people are like cars, so that once we understand the problem, if we find the problem, then we can fix it. And it's analogous to replacing a broken part in a car. But the difficulty is that cars are designed and manufactured by humans in factories. But humans, in fact, are not manufactured in a factory, and they're much, much more difficult and have much more complicated feedback loops. So the assumption that fixing the broken part in some causal chain will remedy the problem is somewhat of a naive assumption. And I'm going to show you how that works with regard to surrogate markers. So surrogate markers are markers that stand in for the outcome of interest. We might assume, for example, that if you have high blood sugar, then if we fix that blood sugar problem, then the complications of diabetes will go away. So here's an example. This is data from the ACCORD trial. The ACCORD trial was a big randomized clinical trial conducted by the NIH, in which people with type 2 diabetes were randomly assigned to standard care or to an intensive therapy that lowers their glycosylated hemoglobin. And as you can see on the left part of this slide, that it appears to work. So if you look at glycosylated hemoglobin, that people in standard therapy had higher values, which is less desirable, than those in the intensive therapy, the lower line. So you can see that there's a substantial difference between these two. So the problem is fixed. But what does this mean in terms of outcome? Well, it turns out in the ACCORD trial, those assigned to the intensive therapy program didn't have lower deaths from cardiovascular disease, the target of this trial. They actually had significantly higher deaths from cardiovascular disease. I have probably 100 or so examples of this same phenomena, but I'll just show you a couple. This one is from the CREATE trial. It was a trial for people with some cancers and advanced renal disease. And these were all people who had low hemoglobin levels. And so the one group was given erythropoietin stimulating agents to increase their hemoglobin, and the other served as a control group and got placebo. And so you can see that group one, the one that got the erythropoietin, had significant increases in their hemoglobin. So this problem is fixed. But actually, the goal of this trial was to reduce the probability of transition to hemodialysis. And what happens is that, in fact, those who had the problem fixed, that is, those who got the erythropoietin, actually had higher probabilities of progressing to dialysis than those in the control group. Here's an example that's very similar. This has to do with angioplasty for people with coronary artery disease. And so you can see at the top here that this person has a lesion in the coronary artery. And so you can insert in a stent, and you can open the stent and open up that for blood flow. So this problem is fixed. But what happens when this is evaluated in randomized clinical trials? So this is from the CoHSTAR trial, an NIH-sponsored trial that randomly assigned people with symptoms of coronary artery disease to PCI, to getting stents, or to optimal medical care. And these people were followed on an average of about 4.6 years. So the problem was essentially fixed in the PCI group. Here are the outcomes. If you look at all-cause mortality or cardiovascular mortality, in fact, there's no advantage of the stenting whatsoever. This, of course, upset cardiologists. But there's been another trial that was published just last year, the ischemia trial. It was very similar, that remedied some of the methodological deficits in the original CoHSTAR trial. So this is a big trial. It was done in 320 sites in 37 different countries. It involved more than 5,000 participants, and the trial cost more than $100 million. And here are the results. People were randomly assigned to stent or coronary artery bypass surgery or to ordinary medical care. And so if we look at cardiovascular deaths, the rate was about 13% in the stent group and about 15% in the ordinary medical care group. And if you look at deaths from any cause, the numbers of deaths were almost exactly the same. So it appears that this trial fixed the problem, but in fact had relatively few benefits in terms of the outcomes that were important. So let's go on and just look at the investments in biomedical research at NIH and in the pharmaceutical industry. So we just make the assumption that most good ideas in basic science eventually become successful pharmaceutical products. But actually, when I was at NIH, Francis Collins, in his first blog, looked at this problem, and he pointed out that among each 10,000 compounds, all of which are getting patented because of their therapeutic potential, only about 250 of those compounds actually make it to preclinical evaluations. And of those, only about 5% make it into clinical trials. In other words, they produce evidence good enough that somebody is going to invest in doing a clinical trial. And out of those 10,000 compounds, only about one of them becomes a licensed pharmaceutical product. So those that go from the sort of early investigation stage actually to investment in preclinical studies is about 2.5%. It's exactly what you would expect on a two-tailed t-test. And among those that make it to the next phase, good enough evidence to go to clinical trials, it's only about 2%, a little bit less than you'd expect by chance. And among those, actually, it's a little bit better. Some years ago, my colleague, Veronica Irvin, and I had the opportunity to look at all of the big randomized clinical trials that the NIH had sponsored, or the NHLBI had sponsored, going back about 50 years. We were interested in this because we realized that a lot of the more recently funded trials weren't producing spectacular results as expected. And what we noticed was that before the year 2000, pretty close to 60% of the trials that NIH was sponsoring produced positive results. But in fact, from 2000 on, things changed. So what happened? Well, in 1997, the FDA passed the FDA Modernization Act, and that created transparent reporting requirements, in particular, clinicaltrials.gov. And so all NIH or NIH-LBI grantees after the year 2000 were required to prospectively declare their primary outcome variables, to list their trials on clinicaltrials.gov, and in fact, to report their trials, whether or not the results were statistically significant. And here's what happened. After those transparent reporting requirements came along, we went from having about 58% of trials producing positive results to down to only about 8%. It's really quite a remarkable change. Another issue that came up in our evaluations for the big clinical trials was this issue that it's one of my favorite quotes from Norbert Wiener, who said, "The best model for a cat is another cat." Oops. Something that happened with the slide. It said, or preferably the same cat. Well, what could he have been talking about? Well, one of the things that we realize is that results of clinical trials often don't generalize well because the people who participate in clinical trials are actually not like those people for whom the results are going to be applied. And here's just one of the many, many examples I have. These are trials of therapeutic agents for people with Alzheimer's disease. So what you see is the age ranges for people enrolled in these trials that are reviewed in this one systematic review. And so this is the medians and then the 95% confidence intervals. But here is the average age of people at first diagnosis of Alzheimer's disease. So what you see is that people who are subjects in these studies are systematically younger in almost all the studies in relation to those who actually have the disease. Here's another great example. This example comes from studies on alcohol, tobacco, and illicit drug use. This was a systematic review done by some colleagues at Stanford. And they estimated that somewhere between 64 and 96% of potential participants in these clinical trials didn't meet the inclusion-exclusion criteria, or didn't meet the inclusion criteria. And common reasons for excluding them were they had psychological problems, they had medical problems, they were too old or too young, they were socially isolated, they lived far from the treatment center, they had low education, they had legal or financial problems, or their substance abuse problem was too severe. In other words, these are almost exactly the same variables that are associated with substance abuse problems. And these trials not only are eliminating a lot of people, but they're eliminating precisely the people to whom you want to generalize the results. So I'm going to just move on to the sort of the final part of this, which is, well, is it worth it? So we've talked about, can it work? Does it work? But if it can work and does work, is it worth taking it? And so people want to know, will these drugs harm them? How much benefit can they get? And how much is it going to cost them? So one of the examples that's been receiving a lot of attention recently has to do with short-acting insulin analogs versus recombinant human insulin. The reason this is so important is that the price of insulin has just gone through the roof. So if you look at, this is a 2019 data, if you look at the cost per year of these short-acting insulin analogs as compared to recombinant DNA, recombinant human insulin, the differences are quite remarkable. But is it worth it? Well, it turns out that there have been 3 Cochrane reviews on this issue. So for type 1 diabetes, they rate insulin analogs as slightly better, but they also note that the differences were, quote, clinically unremarkable. And for type 2 diabetes, these reviews conclude that they're almost identical in effectiveness. So now we've got products that are remarkably different in cost, where in terms of patient outcome, they appear to be quite comparable. Is it worth it? Now, I just wanted to mention a couple of things that are going on in the rehab area, because I think that there are some interesting things happening, particularly with different types of rehabilitation services delivered in clinic and delivered remotely. And we developed an interest in our group in remote provided care. And so there was one clinical trial that I looked at that involved 4 sites and where people were randomly assigned to telerehabilitation with a remote clinician versus traditional rehabilitation at home or in clinic. And they evaluated outcomes for knee osteoarthritis using an outcome score, the CoHSTAR, at 6 weeks and later. So let's look at what happened. Well, in terms of cost, there was a substantial difference. So telerehabilitation was significantly less expensive. But if we look at the outcomes, this is the CoHSTAR, at 6 weeks and 12 weeks, it actually slightly favors the intervention condition, which was the remote service. But actually, the differences are not statistically significant. And actually, if you look at gait speed, they're exactly the same. One of the things that we've been doing in our group is we've developed a big interest in these newer approaches to remote observation and behavioral observation. And this is largely because that everybody for years has been saying we need to do more behavioral rehabilitation in behavioral observation in rehab studies. But it doesn't happen. And it doesn't happen for a couple of reasons. One is that it's expensive and it requires a lot of staff time. And the other is it's boring. And so people burn out on doing behavioral observation. So we've been wondering if we might be able to do some of this remotely. In other words, might we be able to deliver these services in some sort of remote way using modern technologies from engineering and to automate it. So here's an example of one of the studies that we're doing. You see that this person is in a clinic. What you actually get transformed to is a stick figure that's walking. And then here you can see data on knee angle over time and foot contacts. We think this is going to have a big impact on the way not only research studies are done, but we actually are working with some Silicon Valley companies that are able to observe people at home and in the privacy of their homes, but they might be able to be monitored for safety. And also it has a lot of advantages for scientific studies where we can learn a lot about how people are functioning in their own environments. So to begin to wrap this up, I have one more little section of this. But to wrap up the can it work, does it work, is it worth it component, I think it's worth mentioning that these lead to very different methodologies. So to answer the question, can it work, we need laboratory studies. And this goes all the way through phase 3 clinical trials. And typically these are done with surrogate endpoints, which I've argued don't actually represent outcomes that we're interested in. The does it work question might involve pragmatic trials under real-world conditions, and it might use patient-reported outcomes and all-cause mortality. But when we want to get into the is it worth it question, we need to look at completely different research methodologies, cost utility analysis, practice-based studies, and shared medical decision-making. So before I wrap up, I just wanted to mention one other issue, which I think is very important for where we go as a science, and it relates to this third area of healthcare. Because now science has begun to move on between both germs and risk factors. So germs dominated how we constructed the healthcare system in the first era of healthcare. Risk factors and epidemiologic studies was the basic science behind the second generation. But now we have a third generation that looks at things that happen outside the healthcare system. So Neil Halfon argues that this third era of healthcare is arriving. So the focus is now not on germs or risk factors, but it's on achieving optimal health. And the foundational theory is complex. It's life course. It deals with intergenerational and lifespan issues. And the services are very heterogeneous. The financial model is very different because that funding might not be based on the apple picker or the federal judges model, but it might be based on population investments and keeping populations healthy over the course of time. And the goal is producing optimal health for all people. To help understand this, it's worthwhile to look at, well, what are the factors that are most highly associated with outcomes for patients? And so one of these is educational attainment. It's one that's really captured my attention over the last 10 years or so. So I had the opportunity to work with George Howard at the University of Alabama at Birmingham, using data from the ReGARD study. ReGARDS is a prospective study originally designed to follow people for stroke. But ReGARDS has about 30,000 people that have been followed prospectively now for going on 15 to 20 years. And one of the findings that George and I came up with was the realization that if you look at all the variables that predict outcome, they're not the basic biological variables, but they're variables outside of the healthcare system. And one of them is just how much schooling people have completed. So we looked at people who had less than a high school education, high school grads, people with some college, and people with college graduates or more. And you can see that they're very systematically allied. So the more education you have, the lower the probability is that you'll die in the short term. But people point out that, well, there are other factors like demographic factors, income, risk factors, and behavioral factors that may be associated with education. And so we adjusted for each of those, and it does attenuate this relationship, but in fact, never makes it go away. Angus Deaton and Ann Case in their book, Deaths of Despair, look at this as well. They look at the dividing line as having a bachelor's degree. And as you can see that the likelihood of dying of one of these deaths of despair associated with drug overuse, alcoholism, and suicide are significantly higher for people that don't have a college degree. A couple of years ago, Arnie Milstein and I did a systematic review and then looked at the literature in relation to these factors associated with long life. And you've probably all seen this figure before. It's shown a lot that was published as part of a New England Journal series some years ago. And what it shows is that the estimated contribution to early mortality goes something like this, that healthcare accounts for only about 10%, behavioral patterns about 40%, genetic predisposition 30%, social circumstances about 15%, and then environmental exposures another 5%. So it turns out that that this model was just only one of several that had been developed. And so Arnie and I looked at these other models that also tried to estimate the proportion of variance associated with these various factors. And interestingly, they all came pretty close. So each of these 4 or 5 models comes to the very similar conclusion that healthcare is somewhere between about 5 and 18% of the variance in health outcomes. So as we've tried to analyze various factors that are associated with long life, we've come to the conclusion that things that we really invest a lot in healthcare, for example, Pap smears every year versus every 3rd year, health services researchers and epidemiologists have debated forever about whether or not there's an advantage to having a Pap smear more frequently than, or less frequently than 1 year. Well, it turns out the difference between having a Pap smear every year or every 3rd year is maybe hours. It's certainly not a half day of life. Mammography. So if you look at mammography versus no mammography based on studies that have looked at all-cause mortality, it may produce an increase in life expectancy of a couple of weeks. In one case, it was up to a month. But in fact, the meta-analysis overall shows that it has almost no effect. Nevertheless, we don't hesitate at all to invest heavily in that. If we look at total cholesterol versus high versus low cholesterol, that may result in a change in life expectancy of roughly a month or so. Systolic blood pressure actually is more. It could be about a year and a half. Good management of diabetes could be maybe up to a couple of years. But if we look at the social determinants, High risk versus low grade employment in the United Kingdom, it's about 6 years. Smoking, 30 years versus never smoking, it's somewhere between 7 and 10 years. High school graduation versus not having versus having a college degree is about 14 years. And this one, which I didn't mention, but living in this zip code in Philadelphia near the Liberty Bell versus living one zip code away in East Philadelphia, there's differential in life expectancy of about 20 full years. So to wrap this up, I just want to raise this question. What is the return on investment that we get for this roughly $4.3 trillion that we're expected to spend or expected to have spent in healthcare in 2021? Well, first, let's look at the determinants. Suppose that only about 10% of health outcome is determined by healthcare, that social and behavioral factors account for about 50%, and other factors, environment and genetics, account for another 40%. So what happens is that we have 97% of our expenditures on improving health are devoted to healthcare. And we're only devoting about 3% of our expenditure to factors outside the healthcare system. So we have about 90% of the 97% of the expenditure chasing a potential about 3% of the benefit. And conversely, we have about 3% of the expenditure chasing what might be about 90% of the potential benefit. Well, thanks for listening. It's been great to be able to put this together for you, and I'd be happy to answer your questions.